which are going to parathyroid, leave them, rest you tie. Very thin branches. And if you are unable to dissect this much, there is mesh up, you tie in continuity. That option is always there. But desirable option is this, individual branch ligation, the ones which are going into thyroid.
Okay, sir. We should look for the recurrent laryngeal nerve then.
Now, should you routinely look for the recurrent laryngeal nerve or should you not? This is a controversy. The ones which are familiar with recurrent laryngeal nerve, you always answer like this. There are two views, one school of thought who are familiar and are bold enough, experienced. They always dissect and display the recurrent laryngeal nerve. The ones which are not should better avoid dissecting the recurrent laryngeal nerve because in their hands the chances of recurrent laryngeal nerve are very high, injury are very high. Okay. You know about Hartley-Dunhis procedure also? Hartley-Dunhis procedure. Instead of doing subtotal, what you do is remove one lobe complete and one third or half lobe the other side. Right? Indications of subtotal, total, lobectomy, all these things must be known. Radical thyroidectomy, you must know what is modified. Yes.
What is entity near total thyroidectomy?
Near total thyroidectomy. Okay. The words nowadays are lobectomy, subtotal thyroidectomy, total thyroidectomy, near total thyroidectomy, and Hartley-Dunhis procedure, and radical thyroidectomy. Total means you take out the whole thyroid without caring for the parathyroid. Near total means you leave either capsule or peripheral thick 1 millimeter thyroid to ensure that parathyroid supply is intact. Right? Any other question about thyroid? Post-operative complications you must know. If the patient develops respiratory distress, how should you manage? Right? You must know all this. You must also know in which thyroid surgery you must do on-table tracheostomy, tracheomalacia. Right? Okay. Post-operative complications about thyroxine therapy. Which are the patients who require thyroxine?
Total entity or
these are the things that you must. Okay.
So when should be the thyroxine therapy started? At what day, sir?
Pardon?
When should this thyroxine therapy started, sir?
Thyroxine, half-life of thyroxine is?
It is about 6 to 8 hours.
8 days, I think. It is possibly 1 week.
1 week.
Your time limit is 1 week. But you start as early as possible. When the patient has been allowed orally and it has been decided that the patient will require thyroxine, it should be started. Second, third day should be enough. And you start with thyroxine therapy and monitor by TSH.
Sir, why
indications? Yes.
Sir,
like thyroxine, post-operative thyroxine therapy is for 2 reasons. One is replacement therapy, one is suppression therapy. Like in benign disease, if you have done subtotal thyroidectomy for a multinodular goiter, the thyroid which you have left is still open to recur and form a nodular goiter. Now in this case, if you give subclinical dosages which do not cause thyrotoxicosis medicamentosa or factitious thyrotoxicity, that dose is not given. You monitor by your TSH, T3, T4. Keep on giving so that TSH remains suppressed and patient does not have a chance of recurrence. This is benign disease. This is called as suppression. Replacement, you have done total thyroidectomy, you have to give. Right? Papillary carcinoma thyroid, you have done total thyroidectomy with modified radical neck dissection. There the purpose is both replacement as well as suppression. Right? It is less of suppression, I would say, because there is no thyroid tissue left. So it's a replacement. Replacement where no thyroid is left. And suppression where thyroid is left. Like you have done a right lobectomy and you find that the other lobe has fine micronodularity. If you don't give thyroxine in this patient, then chances are that after 5, 6, 7, 8, 10 years it will develop into aggregate nodularity. It is better to give exogenous thyroxine so that TSH is suppressed and that disturbed internal, that feedback cycle is stabilized.
Lifelong thyroxine therapy?
I will not say lifelong. You give for some time, 2 years, 3 years, 4 years, stabilize the patient and withdraw. Right? These patients in any case require a kind of post-operative monitoring for quite some time, right? If you have given for 4-5 years and withdrawn after that, and a patient has remained asymptomatic for another 5 years, then there is no need, you can leave it as such, right? In my clinical practice, I have seen patients coming after 15 years of lobectomy having a tubular on the opposite side, right? But the ideal teaching is that you give for sufficiently long time. Or at least you tell the patient about the possibility of this recurrence, this kind of a thing, so that patient is aware and consults at the as soon as, right? Suprapubic cystostomy indications are expected. You know supracath is available. Still we have indications for open suprapubic is done for trauma, urethral trauma, right? Cystolithotomy, I think very simple. Know the indications. Retropubic approach. Take out the stone. After that, what should you do? Close the bladder
We should suprapubic cystoscopy.
and close the bladder. You should actually see the bladder neck. You should see for the diverticulum. If it is there, large one, you treat it, and see for the prostate if the patient is old. Until you do these three things, you should not close the bladder.
Bladder is closed with. Bladder is closed with.
Yeah, now it has to be closed by in 2 layers.
2 layers.
And suture used is, if it's a neat and clean bladder, close with chromic catheter, because that will dissolve in 5 days. Because in neat and clean bladder, if you stitch with Vicryl, the Vicryl will dissolve in about resistance siling strength after a month. Completely dissolves in 90 days, but leaves the strength. So a nidus will be there. But if it is a heavily infected or flakes are there inside the bladder, then you use Vicryl, not catgut. Retropubic space must be drained. Post-operative complications, catheter care, all must be known. Right? Appendicectomy. Very simple. We ask about various incisions, various positions of the appendix, difficulties encountered. You have opened and you don't find appendix. What should you do? Make it muscle cutting. Still you don't find. Mobilize the cecum. Okay. And drain or not drain. Decide. There is a pus. You must drain. Okay. What are the various complications? What are the various hernias that can form after appendicectomy operation?
Inguinal
hernia. Why?
Sir, because ilioinguinal cutting of
injury of the inguinal vein. This is one hernia. Any other hernia? Right? So that's about. You must see the mechal diverticulum in terminal loop. That's a must, whether or not appendix is pathological. Right? You must know a little bit about incidental appendicectomy. What is incidental appendicectomy? For some other reason, and you are taking out the appendix, right? Hernioplasty, you must know A to Z about this operation. The commonly practiced, that is Lichtenstein repair, must be known, right? And then you must know about Shodley's repair, Stopaz repair, little bit hernia, laparoscopic repair, all types of meshes, Prolene mesh, Vicryl mesh, PTFE mesh. PTFE mesh has any role in the open surgery? It has no role. It's a very costly mesh. It is the only advantage is that this does not promote any adhesions. If it has to be applied intraperitoneal through laparoscope, better option is
no ball fistula or
PTFE mesh is the first, right? Complications, morbidity related to herniorrhaphy because of nerve injury. Patients have local pain all through their life.
In hernia, we should know the Lichtenstein and
the commonly practiced operations must be known. The commonly practiced operations these days are Lichtenstein, Stopaz repair, Shodley's repair, and of course the Besney's repair. Modified Besney's repair will always we expect you to know, because that has stood the test of time, right? If you are in periphery, nothing is available, you do at least the. What are the situations where Besney's repair should not be done? When conjoint tendon cannot be united to the inguinal ligament without tension. If you are having no mesh and you have to unite and tension is there, then you do Tanner slide. All these things are known. Don't try to say to the examiner that Dr. said you know only these and I had not read. You are supposed to know all about it, but details of these operations. Okay? Then gastrectomy, we expect you to know about various labels, various vessels which are tied. No further details. Various types of palliative procedures. Water structures are removed in radical operation.
So what is structure in D3 and D4 gastrectomy?
That you read. That's a theoretical detail. Okay. Cholecystectomy and CBD exploration. Right? When we say this is open cholecystectomy. In the modern era of laparoscopic cholecystectomy, we still do open cholecystectomy. What are the indications? Merzi syndrome, right?
Dense adhesion.
Dense adhesions,
Postoperative
cholesterosis, previous
Patient
history
not-
of surgery,
Patient not fit for anesthesia.
yeah, comorbid condition not allowing anesthesia, or conversion after laparoscopic cholecystectomy. You must know all indications of CBD exploration. And after CBD exploration and removal of stone, what are the indications of bypass operation like cholecystectomy or sphincteroplasty? Right? CBD is 1.5 centimeter, recurrent stone, papillary stenosis. How will you know papillary stenosis?
Recurrent papillary
On table you have opened the common bile duct and you want to know about
we should do the on table intraoperative cholangiogram and
cholangiogram will show passage of dye into duodenum.
and there is CPD is dilated, sir.
CBD is dilated, dye is going into.
The CPD is dilated if there is papillary stenosis.
No, CBD is dilated. If stone is there, then also it is dilated. The best investigation is paraoperative cholangioscopy.
Paraoperative cholangiogram.
Fiber optic cholangioscopy pass and then see. Okay. These are the things we expect. T-tube, it is put when it is taken out. What is T-tube cholangiogram? What is the ideal time? Conventionally, we used to teach that this used to be done on 14th day.
Yes, sir.
Now it can be done. It is said that it can be done any time after say 8th or 9th day, 8th day or onwards, right? You clamp it and then take it out. Retained stone, CBD retained stone. How you manage it?
ERCP.
If all facilities are available, ERCP. Otherwise, irrigation of the tract by MTB or monoctonine. Of course, they are all theoretical. Their success rate is very low, but you must know the options. Okay. Why T-tube is put in, this also must be known. Tracheostomy, I think this is a very simple operation, we don't need to. APR, indications of APR, right? You must know about it. And how to decide, after exploration the abdomen, how to decide radical operability, right? What are the vessels that are ligated, what is flush ligation of inferior mesenteric artery, right? And then total mesorectal excision, the concept must be known, right? Then post-operative complications, especially urinary retention, what are the various reasons for retention? Okay, one is you remove the rectum, it sags down. Second is the plexus is injured. Third is the patient is old and has prostatic enlargement, right? So these are the complications. Mastectomy, when say we generally ask modified radical mastectomy. Otherwise, you must know all types of mastectomy. Simple mastectomy, radical mastectomy, little bit about. And modified radical mastectomy, you must know all details. What is quadrantectomy?
It is the
Okay, I mean, this is lobectomy or lumpectomy, what you call it. Conservative surgery. Okay? MRM, all varieties you must know. Patties, ocean claws, maidens, right?
urban
Label 1, 2, 3 lymph nodes. Which tributaries are sometimes finer details of anatomy can be known. Which tributaries of axillary vein are tight. First part superior thoracic, second part thoracoacromial and lateral thoracic, third part subscapular and others. Takes lateral medial circumflex humeral. Okay? What are the levels of lymph node I have already told. Post-operative complications, flap necrosis,